Morning, everybody. Welcome to this first in a series of 3 webinars today. Today we're looking at specialty in reach in admitted pathways program. Lots to get covered off today, so we're gonna crack on if that's okay. We are recording this just so you know, and we'll make the recording and the slides available afterwards. We've got a really quick Mentimeter session just to start off with, just in terms of understanding who's in the room. So I'm just going to share the QR code. Those of you who've used Menti before will be very familiar. If not, what we're doing is, if you can just use your camera on your phone to scan the QR code, that should take you to an interactive Mentimeter session. And we just want to understand a little bit more about who's in the room today with us, just so we know who we're speaking to. Everyone's all got that. Yeah, if you put the thumbs up when you come in, great. We've got lots of people checking into that. If you're not using your phone, if you're using a separate screen on a laptop, you can also go to menti.com and enter the code at the top of the screen, which is 52409588. So just give a few more seconds just for people to log in. If you scan the QR, it should just take you straight to the first page. This is really helpful for us to understand who's joined us today, so we can reference that through the session. I'm going to be handed over to Jyothi Nippani in a short while, but we'll just move on. I think everyone's just logging in now. A few more people. That's great. We've got 16. How many people on the call? Let's have a quick look. We've got 40 people on the call, so that's fine. We've got plenty of people there. So I'm going to move us on to the first question. So as I said, who's in the room today? That should pop on your screen today. What's your professional background? Hopefully there won't be too many others, and I've kind of got a flavour of who might be here. Great, we've got a nice mix coming up, which is always nice. We don't want lots of the same. A bit of diversity in the room. Oh, we've got a few others. See who I've missed out. Great, we've got 19 people of 20. Great. So a nice mix there, Jyothi, across the room. Excellent. This will really help us understand who we're speaking to. Okay, we'll have a couple more questions towards the end of this session. So if you want to leave that on your phone, and we'll come back to this later on. That can continue running throughout the session. So if you haven't had a chance to input now, then you'll get a chance to do that later on. So I'm going to stop sharing at this point, and I'm going to hand over to our chair for the day, Dr. Jyothi Nippani, one of our clinical associates and national lead. Jyothi, over to you.
Thank you very much, Nick. So good morning, everybody. Thank you for joining us first thing in the morning, although you probably have a busy day ahead of you. This is the first of a series of specialty webinars that we are putting out. These are aimed at, firstly, giving a national push on the guidance that's been developed by specialty networks or Royal Colleges. And secondly, we also want to learn how clinicians in the front line and at trusts have actually implemented this guidance using innovative solutions, innovative rostering or workforce solutions. Thirdly, we want to also understand how we can get senior clinical decision making from and also ownership, not just decision making, but also ownership from specialties very early on in the patient journey in a timely way, thus minimizing the patient waits. So how do we get the patients to the right specialty first time? So that's the aim of our webinars. So without any further ado, thank you very much, the Respiratory team, for kickstarting our webinars. Can I welcome Martin Allen and Sophie Jordaan? Martin Allen is he's a respiratory consultant from UHNM, and he's a national specialty advisor for respiratory diseases. Have you got him on board, Sophie? Yes, brilliant. Thank you. Good morning. The floor is yours.
Thank you very much, Jyothi, and welcome everybody. So we're going to talk mainly today about community-acquired pneumonia for the reasons around that. And we're going to do a double act between myself and Sophie. So I have a variety of roles. I'm the Getting It Right First Time National Lead for Respiratory Medicine. I'm the National Specialty Advisor, but for physiological science, not for respiratory. So the National Clinical Director, we don't have an NSA for respiratory. The NCD is Professor Andy Menzies-Gow, and we thought, given it's on pneumonia, it would be sensible for me to lead this today, together with Sophie, as pneumonia is one of the long-term plan major work streams, and I lead that nationally. So today we're going to focus predominantly on pneumonia, and we're going to look about how we can utilise the CQUIN to help deliver better care. So what we'd like to do is run through some slides. Again, double act. I will do some to talk about the size and the impact of pneumonia. Sophie's then going to spend a little time talking about what we mean by the CQUIN, how to deploy it, and the content of that CQUIN and the benefits we will hope to get from that. And then, if that's okay, Jyothi, we'll open it up to the floor to talk about specifically around the CQUIN and community-acquired pneumonia, but also if it broadens out into other areas, that's fine. We can either pick some of that up or we can discuss it today. So I think it will be very much depending upon what you and what the floor want from us. So we've done some introductions. Sophie, go back one if you want. Would you like to introduce yourself, because I've been doing the talking?
That's fine. Thanks, Martin. Hi, I'm Sophie. I'm one of the senior project managers for the respiratory programme for NHS England, and I work with Martin closely on the community-acquired pneumonia work stream and supporting our networks in sort of achieving the outcomes and the sort of the goal we want to achieve is set out in the long-term plan as best we can. So, yeah, Martin and I have done quite a few of these, touring around, promoting the CAP CQUIN. So this isn't our first time doing this, but please do ask questions and stuff. It's more than welcome, and I will also be able to signpost you to some resources on this at the end as well. So if you're okay, Martin, I will go on to the first slide. There you go.
Yeah. Thanks very much. I thank you. I will go to that, Carl. So pneumonia is an incredibly common condition, and there are two ways of considering pneumonia. It is an infection of the lung parenchyma, the lung substance, and we have a bacterial, usually, occasionally viral, infiltration of that area, and our bodies make a large immunological response. So our airways, but especially the air sacs, get full of unpleasant material, which is bacteria and the white cells releasing a whole range of toxic substances to fight off that infection. We can consider pneumonia as based upon different sorts of bacteria, and that could be a pneumococcal, Haemophilus, the name of the bacteria. But that's complicated, and there are lots and lots of bacteria. So we normally break pneumonia down into two broad groups, HAP and CAP. So CAP is community-acquired pneumonia. And the definition of this is essentially someone who is normally living in the community, so not in a care home, not previously been in hospital, who becomes unwell, often goes to the GP or presents acutely to emergency departments, to EDs. And we're going to focus predominantly on CAP, but we mustn't forget HAP, hospital-acquired pneumonia. So this is a condition where you have an individual who's often in an institution or is already in hospital and is perhaps ready to go home, but picks up an infection actually within the hospital. And that is really important because
Hello.
HAP.
Hello. I'm sorry, but I'm good, but I'm in the middle of.
Yeah, thank you for going on to mute. So I didn't know whether that was an important question at the outset. So HAP is associated with a different sort of bacteria. It's associated with a much prolonged length of stay. So these are individuals who are ready to go home and get a secondary infection as a consequence of being in hospital and not being discharged. So there's an important message here about being discharged early. And that, I think, is perhaps another area for us to consider at a later date. But we also have, unfortunately, from HAP, a very high mortality. So these are people who are deconditioned because they've already been in hospital. They get a subsequent infection and unfortunately have a poor outcome. There is a very specific group of HAP called VAP. HAP is hospital-acquired pneumonia. Yep. And VAP is what occurs on intensive care unit, and it's ventilator-associated pneumonia, and that has an even worse outcome. The numbers clearly of VAP and HAP are much smaller, so we're going to concentrate today on CAP, the community-acquired aspect. So hopefully people are happy and understand what we're talking about, because I realise from the Menti we've got commissioners, we've got doctors, etc. So for our non-medical colleagues, if there's areas that you're uncertain about, like you've raised, please just flag up on the chat and I'll try and answer that as I go along. So why is CAP important? Why is it part of the long-term plan? And that is because it is a huge burden. So, and these are all estimates because there's lots of variability in how you define community-acquired pneumonia. But there's an estimate that says, 1% of the population will get community-acquired pneumonia at some time in the year. So 1% per year, effectively, the adult population are getting CAP. That leads to really quite a large number of attendances at hospital. That's either directly from GPs referring into hospital or from individuals turning up to hospital. And this ranges from individuals presenting with feeling unwell to a cough, occasionally bringing up blood, and almost going through to people with frank sepsis and who are hypertensive and collapsed. So we've got a whole spectrum of presentations of community-acquired pneumonia. It's important because although there is a wide variation across hospitals, it accounts for between 250 and 500,000 admissions. Of all the respiratory admissions, this is the commonest reason to be admitted to hospital. So it's just worth pausing there because the infrastructure within respiratory medicine, so to speak, from a nursing point of view, and often from a senior clinical decision maker point of view, is very much focused around asthma, lung cancer, COPD, where there is an infrastructure of nurses and lead consultants. Regrettably, that does not happen in community-acquired pneumonia. There is often variable ownership of patients with CAP. There is invariably no infrastructure to support the management of patients with CAP. And as we've got in the second bullet point there, you can see with this high volume of admissions, there is a huge spend here. So we're talking approaching, if we bring in HAP, approaching £1 billion worth of spend on pneumonia. So the question here is, what can we do better? And we could spend probably the rest of the day talking about the opportunities for improving management of both HAP and CAP. I realise this is very much focused around where we sit within the front door, and therefore we're going to focus predominantly around the aspects of what we can do in emergency departments, in SDECs, and to a certain extent what happens down the line when people are admitted. So we'd probably at that stage, it's worth moving on to the next slide. And this really is where we've been focusing our work from the national team. And that is to look at what can we do to improve outcomes and what is the evidence. And actually, there is quite a lot of evidence to say if you have, I'll come to that in a moment, there's quite a lot of information about what we can do to improve outcomes for people with community-acquired pneumonia. And that's based upon a lot of work that the British Thoracic Society has done over many years. And they've done multiple audits running from something like 2008. So we need to take what the British Thoracic Society have put forward as the best care and said, okay, how can we enshrine that into good practice? And that's what we did as we developed the community-acquired pneumonia CQUIN. Now, this has taken a little while to get to fruition. We actually had the CQUIN agreed through the national team to go live in 18 and 19, but unfortunately, something called COVID got in the way, and the CQUIN was pulled, and correctly so, as everyone else was somewhat preoccupied delivering respiratory care for that population. So as of April this year, the CQUIN was reintroduced. And what I'd like to do is ask Sophie, she's happy now, to talk through the components of the CQUIN and what we're measuring, what is excluded, and some of the tools that we've developed to help deliver the CQUIN. I appreciate a question flagged up about hot hubs or acute respiratory units, infection units in primary care. So we'll perhaps come to that later on, because there's quite a lot of work and there's documentation about to be released in the near future about that. So if we could hold that as a question and bring that back later on. So Sophie, over to you.
Thank you. So the CAP CQUIN has been based upon the recommendations made by the BTS, and they're sort of best captured in 4 key elements that must be done as soon as the patient sort of arrives and is admitted to hospital. So step 1 is there has to be a chest X-ray done within 4 hours of arrival. There also has to be step 2 to meet the requirements of the CQUIN, a CURB 65 or a CRB 65 score done and added to the medical notes as soon as the person is in A&E, and of course is added to the notes, because that's really important to be able to capture that later when you're updating the data for the CAP CQUIN. Antibiotics are to be received within 4 hours of hospital arrival time. So again, this focus on this 4-hour window, and the prescription is sort of in line with the severity score and of course local guidelines. So those are the 4 key steps that must be done within 4 hours. So we sort of talk about the key parts of this being 4 steps and 4 hours. When we look at participation in the CAP CQUIN, just very, very briefly, there's a key change that's occurred in that should you have chosen to not have adopted this particular CAP CQUIN, you are still required to return the data. So regardless of whether or not you've signed up for it and it's within your group or your batch of 4 or 5 that you have chosen as a trust, that you still have to submit the data. We also, and as many of you will hopefully be aware, best not to adopt more than 5. And our hope this year was that lots of people included the CAP CQUIN within their 5. Inclusions within the CAP CQUIN. So who is included and who is excluded? If you look at sort of the bullet points on this on this slide, this is specifically for adults that's aged 18 and over, and we also have to make sure that the correct codes are used to identify these patients. There was quite a few questions that surrounded people who are in care homes and who are perhaps in respite care, and you'll see that it must be coded as the usual place of residence. Okay, so the inclusions are fine. It's the exclusions that caused the biggest points of sort of discussion and contention when going through groups. So we have some exclusions to the CAP CQUIN. Exclusion 1 is, of course, if they've actually been discharged from hospital within the prior to 10 days of the current admission. So this essentially would then count that as HAP, not as CAP, so they can't be included in the CAP CQUIN. Any patients who are under the care of haematology or oncology are also excluded from this particular CQUIN. And then finally, anybody who's on an end-of-life pathway, they are also excluded from this particular CQUIN. And then additional elements, when we look at the sort of best practice with regards to treating CAP in hospital, these are the 4 elements that are not mandatory but are actually sort of best practice when dealing with CAP. And the first one is the clinical judgment of severity, so using that curve 65 or CRB score, but also taking note of clinical assessment when sort of deciding and then obviously going on to prescribe antibiotics. When it comes to the second one, we've got oxygen assessment and prescription. So it's not again mandated, but this is seen as best best practice when treating CAP. Secondary prevention as well. Lots of people are sadly readmitted within 1 month of having been discharged with CAP. So it's about making sure that we're looking at how we can support people to look after themselves better after they've been discharged. And element 4, which is as a team at the moment, we are working on a standardized patient information leaflet that can be handed out and downloaded easily by all service providers. Is an information leaflet that upon discharge, they are then given this leaflet to explain what their recovery looks like, which also links into secondary prevention, so that we've got the right people coming back to hospital, so that if the antibiotics have not been working and they are not getting better, they do come back. But conversely, if they're actually fine, but they have a lingering cough, which we know what happens after having had pneumonia, they're not unnecessarily returning to A&E. To be able to support adoption of this particular CAP CQUIN and also just support people being able to do it within if they haven't signed up to the CQUIN, but just to be able to carry it out, we put together some tools to assist people. These are all available on the Respiratory Diseases Futures Futures webpage. Please do message me. I'll put my email address in the chat if you don't have access to this. Normally what you can do is click on that link and then it can say request access, and I can go in and grant you access. And there's all the documents and resources that we're referring to today are all available on that page. We also have a frequently asked questions document as well that we keep live. So if there's anything else that's coming through and we're looking, we know more people want the information, we will add to that document and put that on there. Now, and yes, absolutely, we can. I have shared the slides already with the organisers of the webinar. They can distribute these slides absolutely fine, because there's live links in these slides as well to try and make this as easy as possible for people to be able to access the information they need. Looking at the next 2 slides, unfortunately, the audit tool that we put together for the CAP CQUIN is spread across 2. So this first slide is the first half of that particular spreadsheet. And just very, very briefly looking at it, because I don't want to go into too much detail. We've tried to break it down in as much detail as we possibly could as to what you need to capture and what you need to be aware of to be able to submit successfully your CAP CQUIN data. So you'll see there's lots of fields there with drop-down boxes asking various different questions. And again, I know that lots of people in the trust end up retrospectively adding this particular information when they're doing the data uploads. And again, we've tried to make it as easy as possible for somebody who is sort of doing this third hand to be able to populate the information. And we've also separated out the additional elements in the you'll see in the latter part of the audit tool, so that people can also record if they are able to implement those elements of best practice for the CAP CQUIN. We also put together a form that can be downloaded that can assist people with making those checks if somebody does in fact qualify for the CAP CQUIN, just a very quick handwritten form so that you can see if that person qualifies and does indeed need to be able to be have their data sort of married up and then captured on this particular spreadsheet. But as I said, the slide deck will be shared. These are all the links that we have to be able to support people in reading more about the CAP CQUIN, reading more about the BTS CAP Care Bundle, the NICE guidance on prescribing, and then of course a link to our futures page as a respiratory team where you can download all of this information. And then I think what I'll do now, I can see there's lots of questions, and so because of that I will stop. We can start fielding the questions, and yeah, Martin and I will do our best to answer them as thoroughly as we can.
Thanks, Sophie. That's great. We'll pick up. I'm going to turn to Lucy in a moment. If you want to stop sharing the screen so we can, it's a bit easy to see who's on the screen. That's some questions. So Lucy, lots of comments in the chat. If we go through those first, and then if anybody else wants to put their hand up, we'll work through those at the same time. Lucy, anything in the chat?
Thanks.
You want to
we've got
forward?
loads of questions coming up in the chat, so obviously stimulating quite a lot of debates. So I'll just go from the top. So a question from Rob Costa: where do respiratory hubs fit in with this work?
Yeah, so I'll probably take most of the questions and ask Sophie to clarify some of those as well as we go through, if that's okay. So I think we're in a very dynamic position, aren't we, at present? So we've got the acute respiratory infection hubs, the hot hubs as they were. So they're about to be launched as an area for primary care to refer into for evaluation of these patients who may or may not have CAP, because, you know, we recognise that, especially during the winter months, huge numbers of individuals will pick up respiratory tract infections. So how do we recognise those as a bit of an acute bronchitis that we may all get? Is it COVID? Is it an episode of pneumonia? So there's a large amount of activity that will likely flow through those, and they will then select a group of individuals that probably need to go to either ED or SDEC, depending on the local system. There will then be an assessment, and I think following on from that assessment in SDEC ED, a proportion of people will be admitted and a proportion will be discharged. It's often, and it varies hugely across systems, about 70 to 80% of people currently turning up to ED, SDEC will be discharged within the same day, within 24 hours. So they have a 0 length of stay. But that still leaves a significant number of people who are actually admitted. And then there is the opportunity for then to consider how such individuals are placed up on a virtual ward. I think the difficulty we've got is we've got really good evidence about using virtual wards for COVID. COVID is very predictable as a disease because not so much Omicron, but the Delta variants, almost you could follow their oximetry and you could tell when they were going to get better. Omicron is different in the sense it wasn't so much a pulmonary disease as a general systemic disease, and you didn't get the profound desaturation generally. So oximetry in Omicron is a little bit harder to monitor. I think what we then end up with is, if we look at community-acquired pneumonia, it's again a very different disease, and I think it follows a trajectory that is usually predictable, but it therefore is a little bit harder to predict who would go onto a virtual ward. So I think where we can perhaps consider this is in individuals who've got multimorbidity, and to try and facilitate discharge and supported discharge. And we know supported discharge for COPD works very well. So we don't have really supportive discharge for pneumonia, apart from in just a few organisations, but we could perhaps look how that works. But if we consider the average length of stay for most people with pneumonia is 5 days, and most people who are well ill enough to be in hospital will have at least 48 to 72 hours worth of parenteral antibiotics, Unless we're going to start sending people home for IV antibiotics with pneumonia, there's not a lot of headroom here. And I think the important bit here is the clinical monitoring of these individuals. So oximetry per se isn't a good tool, and it's really looking at the news. So are they progressing? And a very useful indicator is looking at the CRP, a marker of infection, and how the CRP is resolving or not, as whether people can go home. So I think there is probably a role for virtual wards in managing CAP. It is yet to be defined, and I think the role may not be as great as we think, because most individuals who can go home actually go home relatively early. So, and if we reflect that a lot of the individuals who get CAP are hopefully colleagues like you on the call, who are normally fit and healthy with no underlying disease, once you start to improve and the markers of infection are getting better, then actually you're fit enough to go home. So, and you don't necessarily need ongoing monitoring. So it may turn out to be quite niche for virtual wards. So I think we don't know for virtual wards. We don't quite know about the acute respiratory infection hubs, what they will work and how they will work within systems. So there's quite a lot of unknown in this, but it's a potential.
Thanks, Martin. Lucy, any more in the chat?
Yeah,
There's lots in the chat.
Loads of questions. So this is more about the sort of practicalities. A question from Nicola Graham: is the CAP CQUIN mandated?
Yeah, so this is a really interesting discussion. So, and Sophie alluded to this. So when the CQUINs came out this year, there are two sorts of CQUINs. There are CQUINs for specialised commissioning, prescribed services, and there are CQUINs for general services. Of those general services, there were 16 CQUINs, and they covered a range of different ones, some of which were relevant to respiratory because of the it was deploying the use of NEWS2, faster diagnostic pathways for cancer. So there was a whole range of them. The CQUIN, what should have happened is the organisation, the provider, working with the ICB, which at that stage wasn't yet a legal entity, should have decided what were the 5 CQUINs they were going to select. So those 5 CQUINs were then theoretically going to get payment. So this is an important bit about how we use money to drive improved care. So the CQUIN is 1.25% of the trust turnover. If you are delivering 5 CQUINs, that means if it's equally distributed, and it doesn't have to be, that's 0.25% of a trust turnover. So the CQUIN, theoretically, if your organisation is quite a big one, and has a turnover of £500,000 or £500 million or whatever, proportionately that money should come through to delivering the CQUIN. The CQUIN is not mandated in the sense that you have to sign up to it, but theoretically, if you don't sign up to do the CQUIN, that 1.25% of your turnover will be taken away from you. So the CQUIN is in your bottom line as a provider. And if you don't bother to take up the CQUIN, and you don't have to, but actually you are going to lose 1.25% of your turnover, which actually is quite a large amount of money. So there's a real financial incentive to adopt a CQUIN. The other aspect, of course, is, as Sophie said, and this is really important, even if you don't adopt the CQUIN, you still have to return the data for the CQUIN. So as Sophie highlighted, the denominator and the numerator, so that the number of people who get the bundle versus the number of people with pneumonia actually has a set figure against that. And will be monitoring that and measuring that centrally. So the CQUIN is not mandated, but it is in a financial interest to do so.
Thanks, Martin.
Can I just
Jyoti's
come
got a
on
hand
that once, Lucy, using my chair's prerogative here. Thank you, Martin, on that. Just wondering, this is an improvement initiative and it is really for our patients. And while I can see that there's a financial incentive, we know that these financial incentives lead to gaming, tick boxing, missing the point, and actually not doing the right thing sometimes for the patients. So how do we actually encourage the clinicians and the operational staff to actually do the right thing and, you know, do the right thing for the patients, because the commissioning is actually changing all the time. The way things are being commissioned are being changed all the time. So how do we actually make everyone do the right thing with or without a financial incentive?
Yeah, well, I think to do the right thing generally needs some support, some infrastructure. So whilst we can do what we can while we're at work, we must recognise that some of our colleagues may not be as enthusiastic about delivering the CQUIN for pneumonia because they are occupied with other aspects of care. So the money theoretically should help support an infrastructure to deliver this. And we know, and we've got good examples where having a community acquired nurse embedded in ED, SDEC, on the respiratory and on the general wards actually improves outcomes. It reduces length of stay. It ensures there is an appropriate follow-up. So as we know, a significant number of patients, pneumonia is a presentation of underlying lung cancer. So a follow-up X-ray is essential at 6 weeks. That doesn't happen in half of the cases. So having the nurses to help support this is important. And therefore, hopefully using the CQUIN as a pump primer to get the nurses in place allows then the nurses to show the benefits by reducing length of stay, by reducing readmission. And as Sophie highlighted, depending on age, but not a big variation on age, 14 to 19% of individuals with CAP will be readmitted. If we've got our nurses dealing with the reasons for those readmission, actually we will reduce readmissions and reduce burden on systems. So there's an awful lot that we as doctors don't necessarily have the time to do, whereas nurses and physios and other allied health professionals can do that. So whilst we should be doing this, there's many other things we should be doing. We just don't have the bandwidth, and therefore using the CQUIN to do that. I think, however, there are other motivations. We do know that unfortunately, community-acquired pneumonia is a very common cause of death. And depending on the figures, 14% on average of people with CAP die. And if we can do something to improve the care to prevent that mortality, then clinically we should be doing that. Again, we're trying to focus that in the CQUIN because, many people will know that, but the curb scoring should be used to identify the appropriate care for patients. So if your curb score is low, then you are able to be sent home safely because we know you're not going to come to harm. If your curb score is high, you should be going to ITU. And actually, probably less patients go to ITU than they should. But even then, those that go to ITU have a 30% mortality. So young people die from pneumonia, and we need to be improving the care to ensure that doesn't happen. So there's improving mortality, improving readmissions, reducing length of stay. So there are lots of reasons why we should be really focusing on pneumonia, and regrettably, we're not. And that's part of our discussion today. We've got to raise the profile of pneumonia. I did see a question about leader. Can I take that as well? Because I think that's really an important part of the work we're doing. Yeah. So if we look at leaders, so these are individuals learning disability and autism, and there is an annual audit of leader deaths. So there is these deaths of individuals with learning disabilities are reviewed in great detail. And that gives us a lot of very useful information. And although it will vary slightly from time to time, and certainly did over COVID, 25% of individuals with a learning disability who are admitted to hospital die because of CAP. And then another 16% will die because of an aspiration pneumonia, so almost like a HAP. So what we're looking at here is well over a third of leader deaths are related to pneumonia. That is unacceptable. So there is a huge amount of work that we're doing as part of the long-term plan group. And today I've just focused on the CQUIN because of time. But we have commissioned, and this is in draft and will be published in the near future, 2 70-page documents effectively, which are state-of-the-art presentations on how to manage aspiration pneumonia and how to manage CAP in the leader population. So there's a lot of work we're doing there, and Right Care also produced scenarios, and there is a Right Care scenario that's in its final drafts for leader and how to manage leader learning disabilities pneumonia in the community. So there is a large amount of work that's happening around that, and we aim probably in the new year now to actually launch these 2 BTS documents together with some other work as a national webinar on pneumonia in learning disabilities and autism group. And to support that, there's quite a lot of work we're doing around soft signs, which are using different tools to identify deterioration, and how we embed the soft signs monitoring for the leader population is again some work that we're doing. So there's a huge amount of area work happening in the leader population to try and improve what are appalling outcomes. So it was just important to follow on that mortality and what we're doing to try and change the dial on leader, because it is such an important area. So the long-term plan pneumonia group are working very closely with the National Clinical Director and the whole of the learning disabilities team within the NHS. So hopefully that answers the leader question.
Thank you, Martin. Oh, sorry. There's just one tiny. That was a really comprehensive answer. Thank you, and really great to hear that this work is being done. Although the figures are obviously shocking. There was one other element to that question, just that I think would be great for you to answer. So the question is there a requirement for to identify those leader deaths as part of the CQUIN return?
No, there isn't. So the problem we have, and we looked at this in great detail. Unfortunately, learning disabilities doesn't have a code. Now, I know that sounds intuitively rather silly, but there is no clear, I don't like the word label, but go with me. There's no clear way of identifying people with learning disabilities. So someone with learning disabilities may have cerebral palsy, they may have Down syndrome, trisomy 21, they may have a whole raft of different conditions. So you can't identify those easily to put them in the CQUIN. So we discussed it at great length, and therefore we couldn't put them in specifically as an inclusion or as an exclusion. But if we look, although the outcomes, as we said, from the leader population are appalling, the numbers overall compared with the 500,000 population who are admitted with CAP, the leader population is really very small within there. So it would have been too difficult for organisations to actually identify the leader population for the CQUIN. So we tried to work that through, but it became too difficult for providers, and providers would be unhappy to actually deliver that amount of data collection. So we thought about it in detail, but it was not doable. And when we develop a CQUIN, we need to seek not only what the clinical experts think about what should be doing, but also is it doable by providers? Because as Sophie highlighted, there is those aspects of data collection that have to be returned nationally, and if it is too complicated, it becomes not viable. So we need something that is important, something that makes a difference, but something that is achievable and collectible by current standards. And you can't ask, if an organisation is admitting 4,000 patients with pneumonia, which some are, you cannot ask each individual doctor or whoever it is to look through all of those cases to see if they had learning disability. So that's why we did it.
Thank you. Thank you.
Lucy, I'm going to just, I'm mindful of time. There's probably questions in the chat, which there's quite a few there related to the CQUIN. I just wonder whether Sophie and or Martin could respond to those in the chat, perhaps. We've just got a couple of Menti questions that we just want to get your thoughts, because you've listened to Martin and Sophie very, very eloquently and describe what's happening at the moment. We'd really like to get your thoughts as well, to get some feedback from your perspective. Just a couple of questions that we want to ask on the Menti platform again. So if you're able just to sort of go back to your phones again, and if you need to log back in, the QR code is there again. If you do need to, just a couple of really simple questions from our perspective. You've listened to Martin and Sophie there, but what do you think are the key interventions which will help achieve some of the desired outcomes, particularly around the CQUIN, but just as Jyothi mentioned, just around just in general, just even irrespective of the CQUIN, what do you think are those desired outcomes? We've already got one that's popped up there, and that's around collaborating with community services and ambulance services. Any other thoughts from anybody else in the room? And Jyothi, I don't know if you want to respond to any of these as they come in.
Yeah, I think collaborating with community services and ambulances is a really good one to start with. I know some work that's being done by Matthew Nada Kim. I'm sure he's collaborating with you, Martin and Sophie, about how you can get ambulance services do the red, amber, green. If it's a red sign, they go to the hospital, amber, they stay in the community, and green doesn't need any follow-up. I'm not sure whether you're collaborating with him on this.
Yeah, so yeah, I work very closely on part of the group that are devising these. We've got one pilot centre that is doing that up in Liverpool, where they're embedding respiratory individuals within the ambulance to try and support that. I think there are other opportunities as well as we develop this. So what is the role of having a CRP, C-reactive protein, undertaken by the ambulance crew as a point of care test to identify and triage patients? So there's lots of opportunities here about that. But I think one would hope if we develop the acute respiratory infection hubs better, actually patients will have an easier access, so they won't necessarily have to wait and become unwell and then dial 999. We'll be in a position of actually being able to access expert opinion through those areas. And then I think that would be a better triage. So whilst that is an opportunity, I think we should be looking at different ways of doing it.
Brilliant. Yeah. See, these are all things people are putting up in the chat, on the Menti. Teaching junior doctors regarding CAP management, timely admin support at the right time, in the right environment, such as SDEC, ED, and coding department. Better access to advice and guidance in the community. That's something also that's coming up quite a lot, Martin and Sophie. How do we have a networking within an ICS or within a big range? How do you get better access to advice and guidance so that you can actually do the right thing and give the right support, especially in deciding whether somebody needs to go to the hospital or can stay at home? So
yeah, one of my colleagues, I think, is on from Stoke. So actually, we pioneered this back in 2008 by running a hot clinic whereby doctors, practice nurses, anybody could ring a consultant who would have a mobile phone and actually will give immediate advice, and if necessary, see them in the clinic the next day. So that is well established. That exists as a area of improvement in the getting it right first time report. And I'm pleased to say that in the acute respiratory infection hubs, the ARI hubs, there is a flow chart that's coming out that once a person is seen in the hub, there are 4 limbs, one of which is obviously discharge home, one of which is transfer to hospital, but there is a limb in there that says contact advice, and that could be a hot clinic like I've described, or it could be an SDEC, but that is actually enshrined in the documentation that's coming out. We're just waiting Amanda Pritchard to sign it off. So yeah. that should happen, and that should be commissioned.
And there's a lot on the chat as well, and on the questions about the use of virtual wards in managing this, not necessarily to prevent an admission or a conveyance, but also to, send them home early and manage them on virtual wards. I know you've touched a lot on virtual wards already, but is there a place that you know that's already started doing this, and how have they done it, if you know?
Yeah, so I think many organisations will have quite an effective supportive early discharge service for COPD, and there is an element of creep because about 20% of patients with CAP also have COPD. So quite often the COPD teams will take patients under their wing who've also got an element of CAP. So this has been happening in an unspecified way for many years. I think what we don't have are very clear guidelines about it. There is a very good research base, as we know, for supportive discharge for stroke, for supportive discharge, especially for COPD. There is relatively little evidence for supportive discharge for pneumonia. And I think, as I've said already, most individuals with pneumonia are fit and healthy and don't have an underlying comorbidity. And for those individuals, there's probably a relatively little role for a virtual ward, unless you are going to give home antibiotics. And I think there's a question about that. You may have a role for home antibiotics if you've got an empyema, or if you have a lung abscess, which are consequences of CAP, which we've not talked about. But I think it's probably a limited role in the fit and healthy. But for individuals with comorbidities who need that little bit of extra support, then it may be beneficial. And I think the mean length of stay is 5 days from admission to discharge. Given, as I've said already, that at least people will be on parenteral antibiotics for 3 days, a virtual ward isn't going to shave a lot of time off for this population, I don't think.
Thank you.
Because they're underlying, they're normally fit and healthy.
Sure. Yeah. I mean, about the constraints and enablers, lots of very key important things. Workforce, we know, is a constraint. Access to primary care for transformation, ICS teams, primary care training, time capacity, all this is coming up. Constraints are buy-in from management. And I think your, financial model that you said could be a very good buy-in for the management, as a lack of knowledge about the CAP, and you've done a great job in explaining that. One thing that's standing out for me here is that patient access to support in a timely and truly accessible way. I think if this is something we can solve, if we can actually somebody can be there at the end of the phone for patients and give them timely advice, then sometimes we can actually stop them from pitching up in ED if it's inappropriate. So is there anyone who has cracked that timely access to a patient?
Well, I mean, this really sits within primary care, doesn't it? About how an individual doesn't present with pneumonia. An individual presents with a complex of symptoms, and signs and supportive diagnostics will make that diagnosis of pneumonia. So I think it's a question that's upstream. It's not how do we manage someone with pneumonia. I think it's how do we identify and support individuals with respiratory infections. And that's what the ARIs are designed to do, to identify an individual who has a simple infection that will resolve without any intervention versus those that actually are quite sick and need to be hospitalized. So I think it's taking that symptom complex, making a diagnosis, and then managing that diagnosis of acute bronchitis versus CAP or whatever it may be appropriately. So, and that's where I think the ARI really have their role, isn't it? So this is a primary care, having an appropriate individual to help support that triage, directing them into an ARI, and the ARI then doing the appropriate assessment clinically, history, examination, possibly diagnostics, and then deciding where that goes. So I think that model is the one that we probably have to adopt for now. And I think, as I've said already, enshrined in that document of the ARI is the hot clinic, the open access for advice. So those individuals who there's uncertainty about can actually be discussed. And it may well be they just need a chest x-ray and they can go home, but that can be seen in an SDEC or as an outpatient setting. So I think that sort of working needs to get better, and I see the ARIs supporting that.
So yeah, I think looking at the time, it's 10:28. Lots of questions there for you to answer. I hope you don't mind if you go through those questions at some point and put some answers there. We'll feed them back to the delegates after the session. I think let's close the session. Thank you so much, Martin and Sophie, for coming on today. I'm sure there's a need for another follow-on session at some point, and we'll be in touch with you and we'll get that organized. And thank you